2, it will be Sarmita and Monica. Okay, hell yeah. I'm Sarmita Tūbel from Latvia, and okay, my colleague is Monica today, yeah, from Estonia, and it's very big pleasure and honor for me to introduce you to our first keynote speaker, and it is Wiebke Scharf-Rethfeldt, and she is a full professor of speech and language therapy. She is a director of therapeutic sciences in SLT program at the Hochschule Bremen. She is interested in assessing and identifying developmental language disorder in monolingual and multilingual. And it's really the question of today for us all. She is, let me say some words. I know Wiebke maybe for 15 years and maybe more. And for the first meetings in previous European Speech and Language Therapists Association, CIPLO, I remember Wiebke as always being aware of speech and language therapy across Europe, and not only. She had always some questions, some remarks, some comments, some suggestions, and she was very, very active in this. And now she's more active because she is in the executive committee of IALP. It's International Association of Communication Sciences and Disorders, and I'm very happy about this. So maybe with your presentation, you will introduce by yourself. It will be better. So Wiebke, floor is yours and you are welcome.
Thank you. Thank you so much for the kind introduction, dear Sarmita. Yes, we know each other for actually 22 years, I almost think. So it's been a long time. Time flies. Labrit, labasritas stereomikos. And thank you, dear President of the Estonian Logopedists Union and Committee, dear Helje, for your very kind invitation and thoughtful welcome speech to this great joint Congress of the Baltic States. I feel very honored to speak to you today and to provide an insight into my work, which mainly focuses on early assessment of developmental language disorder, or DLD, and SLT intervention in multilingual children from diverse culturally and linguistically backgrounds. As Helje has mentioned in her introduction, accurate identification and diagnosis of a language disorder in kindergarten and school-aged multilingual children is a continuously challenging issue in SLT. In addition, in the past 10 years, much has changed. In the field of SLT, speech and language therapy, which has advanced to alternative approaches instead of norm reference tests. The diagnostic label has internationally changed from specific language impairment to DLD. And next to other new research, an international survey has been carried out by the IALP on assessment practices of multilingual children for DLD, which identified access barriers also to SLT service provision, which SLTs, but also teachers, families, pediatricians, and other relevant professionals on assessment process should know about. And all this thanks to the fact that there have always been questions, as you put it, Sarmita. It's really important to keep questioning and being curious and being willing to learn. As you also mentioned, I'm the vice president from the worldwide organization representing more than 300,000 SLTs in the International Association of Communication Sciences and Disorders, which is called IALP or ILP. And you're also welcome to be members of IALP. By citizenship, I'm from Germany. a country in the center of Europe, which has always been a country experiencing large-scale immigration and consequently linguistic diversity. In the past 60 years, it has accommodated around about 20 million migrants and refugees from other countries with diverse cultural backgrounds and, of course, diverse languages. However, Germany's public systems, education systems, are still struggling with the transformation from operating rather monolingually. And so people who are still following a monolingual mindset are also challenging. During the past decade, Germany has been among the 5th major host countries of refugees and asylum seekers worldwide. And you can see from the heritage and background that it's also cultural diversity and linguistics have been changing. More, the number of migrants, including refugees from diverse parts of the world, has increased compared to recent years. So it's a mistake to believe you can adapt and acknowledge the current state because there will be always new languages and there will always be new cultures coming and being in contact with us humans. So this accounts for the diversity of cultures, languages, and dialects, as well as there is no monolingual standard anymore, I would subsume. Instead, diversity is the new normal. So with this presentation today, I will briefly summarize what we know about current terminology and prevalences of DLD, and that multilingual children are prone to both over-identification and under-identification of DLD. I will then report on an international survey on assessment practices for DLD, before I will give an overview about factors acting as potential barriers to provide an appropriate level of service, in order to then provide recommendations for overcoming those barriers. Previous studies have highlighted that about 40%, up to 55% of the children, no matter whether being monolingual or multilingual, do very likely experience communication difficulties when from socially disadvantaged backgrounds and or receiving limited exposure to the languages of their environment. Approximately 10% of all the preschool-aged children that have severe difficulties are meeting the criteria for language disorder. Before I will get back to the criteria in a moment, let's have another look at some data on prevalences. In 3 per 1,000 children, there is a speech disorder in connection with a congenital hearing disorder. Another 1% of the children may develop an autism spectrum disorder or fluency disorder, while in more than 2% of all children, the speech disorder occurs in connection with a comorbidity, such as in the context of a medical condition, a chromosomal disorder such as Down syndrome, or due to brain damage. And much more frequently, approximately 7.5% of all children, based on statistics in the UK, are affected by a developmental language disorder. So this is 7 times more common than autism spectrum disorders, or 46 times more common than childhood hearing impairment. It is the most common neurodevelopmental disorder affecting children, no matter which language background, and this sets the frame of today's presentation. Just to remind us of what DLD is and why early identification matters. It is a term to describe difficulties in using and or understanding spoken language, no matter which language is used. Whereas the difficulties occur with no relation to any known cause, that is, without any association with any sort of medical condition. And these difficulties create barriers for children to socialize with others, and they're also very likely to impact their academic performance as school and beyond as well. And these difficulties do not resolve spontaneously, which is why affected children require special therapeutic intervention to overcome the difficulties depending on the demands, as the difficulties cannot be fully healed. DLD is a lifelong condition. But helping those affected to acquire strategies to cope with the difficulties of the disorder, which form an essential part of an SLT intervention, can make a difference for the affected individual to participate and perform, which is why early identification really matters. So DLD is one of the most common neurodevelopmental disorders, which may affect up to 7.5% of all children. However, there are no clear estimates about the prevalence of DLD in multilingual populations, as research has been confounded with the use of standardized language tests that are insensitive to non-monolingual language experience, or studies inclusion criteria were defined as a score with the normal limits on a non-verbal IQ test administered in the societal language of a Western language, with both factors bearing the risk of leading to underdiagnosis or overdiagnosis in children being exposed and using more than one language. So with regard to the evidence base, most studies, especially longitudinal studies examining language development in children with DLD, have been conducted on monolingual, mostly English-speaking children. In the past, in most studies, children from homes that speak languages other than English have been excluded from participation in those surveys. So an analogy used to describe the challenges we face when assessing and evaluating DLD in multilingual children is often referred to as oranges masquerading as apples, in the sense of difficulty or disordered. However, we may assume that multilingual children can be likewise affected with regard to current evidence, which is based on processual neurodevelopmental aspects of DLD. We can assume a genetic component for DLD, which is there from birth on, and consequently, it has no impact whether a child will then, with these genes, grow up with one or more languages. So there is no reason to think that the prevalence in multilingual children would be significantly different from that in monolingual children. To explain the different prevalence rates of DLD that were reported in different studies, as you can see here, it can be assumed that age differences between the samples and the methods employed to test for DLD still remains an issue. The more language specific the tasks, the worse the performance. This especially accounts for the tests on grammar and vocabulary used, which especially accounts for children who are exposed to more than one language. However, the broader skills, including other areas of communication skills, the more mixed the profiles of performances get. That is why a neurodevelopmental perspective, considering processing-based deficits and related indicators or clinical markers for DLD seems much more promising to identify and to differentiate a difference from a disorder in multilingual children. So as you can see, which are typical processing deficits which can serve as indicators or clinical markers in monolingual children, but also in multilingual children with DLD, with a developmental language disorder, to differentiate them from their peers who grow up with typical healthy language development and multilingual children with typical language development. So many children with DLD have problems with verbal short-term memory, learning statistical patterns in sequential input, or learning associations between words and meaning, their semantics. All of these issues affect learning, language learning, regardless of the number of types of languages spoken, which is why DLD is evident in all languages of a multilingual child. So these are typical processing deficits. A related inherent capacity could be measured with tasks which target these skills. These are tasks such as non-word repetition tasks or sentence repetition tasks, and other tasks as part of dynamic assessment, which is testing procedural learning. So the performance may be associated with problems in learning due to restricted language processing skills. And this is something totally different than testing for linguistic knowledge. So while a solely focus on linguistic indicators, such as limited vocabulary or grammar, could also reflect, of course, a restricted environmental input or exposure to enough languages to learn, than a learned skill. Functional language and communication skills may not only be linked to age and cognitive development, but to the target, to the language exposure and learning opportunities a child may receive. A child, whether monolingual or multilingual, may present with language difficulties in the domains of vocabulary and or grammar. This includes semantics, or the meaning of words, and vocabulary size, or vocabulary repertoire, and morphology and syntax. However, while many linguistic deviances, like limited vocabulary size, may be indicators for DLD in monolingual children, they may not indicate a language disorder, but may be viewed as such by an underinformed SLT. Furthermore, differences in morphosyntactic rules across languages may result in distinct rates or orders of acquisition in monolinguals versus multilinguals. This diagnostic focus is in line with the Catalyze Consortium's endorsed use of the term developmental language disorder, DLD, for a condition which affects an individual's ability to use and understand language, which reflects the understanding of DLD as a functional impairment. Interestingly, Bishop and her colleagues assumed that terminological confusion and the use of non-evidence-based diagnostic criteria have impacted access to services for these children with DLD for several decades, and that it had a negative impact on the external validity of research in relation to practice too, according to McGregor. The former term, SLI, was often used in a way that does not align with clinical reality, especially not with children acquiring language in multilingual settings. For the diagnostic label specific does neither align with a disorder that is not specific to a specific language or specific conditions, nor does it align to a processing disorder that will develop different linguistic symptoms depending on the languages used or involved. That is why assessment should focus on a range of domains that affect language learning in general. That is a processual approach. More diagnosis should also not be given based on a test cutoff score. And this accounts also for tests measuring an IQ, which according to the consortium is not required anymore to give diagnosis. And this is very different from the past decades. As diagnostic criteria and consequently choice of measures for assessment are assumed to have impacted access to SLT service before this new recommendation, it is interesting to find out how clinicians nowadays assess for DLD in multilingual children. A recent study by the Multilingual Multicultural Affairs Committee of the International Association of Communication Sciences and Disorders was conducted as a survey of diagnostic criteria for DLD in multilingual children to discover how clinicians apply the catalyzed terminology and diagnostic criteria to multilingual children in different parts of the world. This international web survey was used to survey 354 participants from 44 countries about their assessment practices and clinical opinions about assessing multilingual children for DLD. Grouped by continent, you can see that most responses came from Europe, with smaller numbers from Asia, North America, Oceania, and Africa, with the smallest number of responses from South America. Most participants reported to be monolingual, as many SLTs are. Less than a third of the participants reported being multilingual. Of those multilingual SLTs that reported 2 native languages, these were most often one of the principal languages of their country. 72% felt confident to differentiate between multilingual children with language disorder and those with typical language development. As seen in other studies, multilingual clinicians with some experience and have more professional experience than 15 years felt more confident than monolingual clinicians to diagnose DLD in multilingual children. We also asked clinicians about their opinions on appropriate service and possible barriers to referral. From this study, but also from the literature, we know about several challenges in SLT service provision for multilingual children. Many children with DLD are underserved, no matter whether monolingual or bilingual. However, there is a high risk of being misdiagnosed for multilingual children, and misuse of services arises from intrinsic factors and extrinsic factors. Among the extrinsic factors, there are lack of interpreters, lack of sufficient time to conduct comprehensive assessments, but also clients' lack of knowledge about services and how to access them, as well as culturally different understanding of what constitutes a disorder, and also lack of financial and human resources, such as insurance coverage, to name just a few. Moreover, intrinsic factors provide challenges to provide SLP services for multilingual children, such as
lack of knowledge and awareness of the client's culture, or knowledge about multilingual acquisition. I don't know about your initial education, but I can say that for Germany, language development in multilingual population and assessment and therapy is not yet integrated as a standard in their curricula. Another intrinsic factor is language mismatch between client and clinician. And this also accounts for bilingual SLTs, because you are not bilingual in all of the languages you may see on your caseloads. Another one is lack of normative data on multilingual development in diverse languages and for diverse language combinations, because we know that the combination of, are they rather similar languages compared to when it comes to linguistic features, very distant languages, makes a difference and has an impact. And actually, we have no language or normative data on languages from Eritrea, from African languages, Twi languages, and it's actually based on only 2% of all the languages of the world. We have some information on language development on. But let me get back to the list. So another one is, of course, if you don't have normative data, you will also have a lack of appropriate tools. You don't have the possibility to take a test. This also includes culturally sensitive assessment tools and norms, which are a prerequisite to report for school placement in some countries like the US. So often underestimated factor is limited self-efficacy. Self-efficacy refers to an individual's perception of how well one can execute a course of action, in this term assessment, which is required to deal with prospective situations, or somewhat like confidence to perform a task, perform a coping behavior when task complexity increases, and the ability, and this is also self-efficacy, the ability to withstand certain tasks despite performance-related expectations. So this may be having the task to perform an assessment, to perform the task by using a norm-oriented test, and have enough self-efficacy to withstand, because you know this is not the optimal or right choice. So the mentioned barriers to equitable SLT service access may mount up to limited self-efficacy as the tasks become more complex. There may be limited time to undertake continued professional training for working with children and families from diverse backgrounds. In most countries from where we are, if I may say so, imported the knowledge for our education, clinical education, the majority SLTs are monolingual. So we imported a lot of textbooks from the UK or Anglo-American literature. So the assumptions of typical and deviant language development that are based on Western and middle-class monolinguals may also enhance this mismatch. Further, the lack of culturally appropriate assessment tools, lack of normative data to provide developmental trajectories for multilingual children, and diverse language combinations to evaluate present barriers. These then lead SLTs to, despite best practice recommendations, to still use standardized assessments that are considered inadequate or inappropriate for that population. This applies especially to school-based clinicians, where the results of monolingual norm-reference tests are often required to evaluate language skills of a multilingual child for placement and access to services. Such policies, which dictate the use of monolingual standards of assessment and norms to derive a diagnosis, are unlikely to be in line with culturally safe and appropriate practices for multilingual children. Let me show you why. One is when we think about the recommendations to overcome these barriers, one is the self-efficacy ability to withstand, to apply monolingual norms, despite related to expectations. Monolingual norms, including standardized tests, should not be applied on monolingual children. Consequently, not. It's largely recognized that norm-reference tests are not suitable to use with culturally and linguistically diverse populations, since populations outside the theoretical base and norming sample do challenge the validity of this test. So when it comes to multilingualism with different language profiles, varying onsets, and varying exposure patterns or cultural diversity, these instruments have a wrong comparison group, and additionally do not tell us clinicians enough about, for example, the children's learning strategies, problem-solving skills, and strengths and weaknesses, which the latter would actually be a problem in testing in general. Even if assessment would embrace both or all languages as it should, monolingual mindset behind the test development, adaptations and translations makes use of these tools less applicable, both linguistically and culturally. Monolingual mindset as a basis for the test would then be, in a way, remain even with the bilingual normative data. So even if we take the monolingual mindset and test it on bilingual samples and subjects, it would still be a monolingual construction. We are comparing monolinguals with bilinguals. The development of a multilingual norm reference test suitable for all bilingual children is absolutely unrealistic due to the heterogeneity of the client group. Language attrition and change of languages in exile or due to the impact of digital media, receiving more YouTube videos in English, or watching more, I don't know, Netflix or whatever streaming things, you know, this would also need to consider it, because more time with another language means less time with the other heritage language. And also test adoption is not an option, as tests are always developed, constructed, and evaluated to address a specific population. After all, tests were developed to ease the workload of an SLT, to support our decision-making process, but not substitute our decision-making process. But after all, it has always been the SLT's decision and responsibility to derive and explain a diagnosis. There are several alternative measures to be preferred over the availability norm reference measures with multilingual children, as norm reference measures lack diagnostic accuracy and lack of cultural and linguistic discrimination. So this flow chart presents the inductive approach, which I call inductive approach, which covers parent or other parental reports, pre-assessment questionnaires, which you can also download for free here as a bilingual patient's profile, and the multicultural and intercultural case history information. And then a combination of methods and measures such as non-word repetition, language sampling for analysis, non-linguistic cognition, and criterion referenced assessment based on current evidence and dynamic assessment. The higher validity and reliability of holistic approaches and a mix and combination of different measures and tasks has been reported as more valid in the literature. I would like just to go briefly back to the study I reported on. In one of those open questions, the participants were asked to identify the reasons that multilingual children in their country may not access SLP assessment. Interestingly, many of the responses correspond to what we know from the literature. Most clinicians estimate reasons such as lack of knowledge from professionals, such as physicians and teachers, and that language problems are explained with multilingualism. So this again refers to underdiagnosis. The darker the color, these are the main categories, the more often it was identified as a barrier. Many clinicians believe that parents here are not aware of the option and that there is a lack of knowledge about the multilingual development and also a lack of multilingual SLTs, why multilingual children may not access SLP service after all. Moreover, cost reasons were identified to provide a barrier to access service in some geographical regions. And this is not about costs covered by insurance only, but it also costs money to take the bus to ride, take the time off work to go and seek clinical service, etc. When comparing to the literature, barriers to equitable access seem to have changed over time. While earlier investigations reported that clinicians perceive differential diagnosis of different from disordered language development in bilingual children as a barrier, newer, later studies rather report on challenges such as obstacles when working with interpreters. Our results here show that interpreters were not among the most often considered estimates, though. Notably as well, barriers to access SLT services seem less language specific, which is interesting. Low community awareness of available services and the purpose they serve, affordability issues, and the lack of knowledge of the options of the healthcare systems are more commonly reported. As service providers, clinicians are also responsible to educate families on the myths and misconceptions about bilingual exposure or multilingualism. Therefore, supporting families in using their primary language is one of our responsibilities. Parent-child interactions in the heritage languages have a broader social impact and extend beyond the positive influence on language development. So, although there is no size-fits-all approach, and therefore it may be helpful to provide advice, to check and maybe regulate what caregivers were told by, for example, the pediatrician or the teacher or the neighbors or even the people on the street or whatever they may have learned from the internet. Also, information on what SLTs or how SLTs work and the roles of how to support intervention is important for them to know and can save resources such as time and money on the long run. Families must be made aware that they have the right to ask for language interpreters when they have difficulties to communicate with a clinician, and service providers can also advocate for CLD or cultural linguistic diverse families and clients while working in conjunction with other professionals. Additionally, educating families on what resources exist and how to access them and how to use them is very important. Uncertainties, confusions, and stressors can be prevented by providing a structure to the interaction and setting clear expectations. Parents and caregivers would benefit from partnering with community agencies and non-profit organizations to build their resources and gain access to necessary information in supporting their child's communication and developmental needs. And finally, the clinician could help create or establish contact with support groups for parents and caregivers who share the same linguistic and/or cultural background. The mentioned study by the Multilingual Multicultural Affairs Committee of the IALP confirms that good quality initial education addressing multilingual language development and continued professional development are key factors for SLTs to gain confidence in assessing and serving culturally and linguistically diverse clients. So teaching establishments could provide courses in the areas of diversity, multilingualism, assessment of culturally and linguistically diverse clients, planning and delivery of culturally sensitive intervention to allow SLTs to become more competent and more confident in serving these diverse populations. Students should be given opportunities to manage clients with diverse backgrounds effectively very early. This is not only about increasing graduate coursework and reception of research on this topic or offering clinical practicum with the target population. Students should be encouraged to experience themselves in a different culture and language through educational and cultural exchange, for example, Erasmus programs. This will allow them to gain a deeper understanding of themselves and those around them. It will deepen their knowledge of foreign cultures and strengthening international relationships as well. Professionals that may not be able to leave their working area for various reasons and commitments could become, for example, host families. Why don't hosting a child or a young student who does not share the language with you? You will experience in your own living room, in your own kitchen, what challenges can be. They could start to become culturally competent in their own living room, and they will acquire valuable competences that will transfer also to their professional knowledge. Intercultural training and service can go hand in hand. In terms of outreach for SLT service in your community, it would be ideal if supervised clinical placements could be offered to SLT students to work directly, for example, with migrant minors in open centers. Opportunities could also be offered for adult migrants to participate in workshops for adults in relation to stimulating speech and language acquisition and preventing impairment. While such services could be free to migrants, they would be of mutual benefit since students would be gaining direct exposure to working with these communities. At the same time, an increase in awareness of health services amongst the migrant families may be promoted, and it should be an objective of policymakers to target this issue, because individuals who may need SLT or may wish to refer family members for the service may not know how they can do this and where to access it. Healthcare services should be provided with the assistance of mediators, interpreters, cultural mediators. While implementation of promising strategies add costs to service providers, employers, and governments, it can be argued that extra costs related to identification of communication difficulties would be beneficial given the gains in quality of life for individuals whose communication skills improve on intervention. In the case of children, late identification of a developmental communication disorder would have direct negative effects on learning, behavior, and social interaction. The later a child is identified, the more costly it becomes as a result of the additional support services needed. And therefore, prevention and early identification and intervention may be less expensive after all. Needless to say that the European Union offers plenty opportunities to apply for humanitarian project funding, students exchange, or research networks. So there are many steps that need to be undertaken on diverse levels, for example, with the participation of professional associations, research, educators and families, university study programs, educational collaboration projects like summer schools, and many more ways. In a nutshell, and I will conclude with this, my presentation for today, despite the high risk of social and academic difficulties associated with the disorder, many children with DLD remain and still are underserved, with some groups of children being more likely to go without services than others. The result is that children from multilingual backgrounds, no matter where they live, may be overdiagnosed or underdiagnosed with speech, language, and communication difficulties, but more likely being underdiagnosed. And actually, it is not about either DLD or lack of exposure. Eventually, it can be both. There can be children with DLD which experience a lack of exposure in more than one language. Service inequities may be related to minority linguistic, but also socio-economic and ethnic status. There may be unequal access due to linguistic barriers to the same health services and resources in the same conditions for those speaking a language different from the majority language of a country. Other studies confirm that children who speak the majority or societal language of a country as an additional language are less likely to be identified as eligible for service than monolingual children. In the past 2 decades, research on service providers has indicated that both monolingual and bilingual SLTs feel both inadequately equipped to support the unique needs of clients that speak a different language from theirs and clients whom they do not share a common culture with. So it's actually about clinical self-efficacy, an important construct that has been known to impact clinical outcomes. So with this, I leave you with, if you're interested with more reading, but before I end, I would like to express my gratitude and special thanks to the MEC colleagues and co-authors of this international survey, which are Lemierda McNeely, Marja Larssonen, Natalia Meir, Hada Awudbol-Oz, Sini Smolander, whom you will also hear in a few hours, Barbara Goulart, and Emily Hunt. And if you want to use this QR code, you can access the study. Thank you. Tenan tait telepano est, dekoyamus demisi paldis pa yusu, uzmanibu, and excuse my expressions, and thank you very much for listening.
Thank you so much for sharing about the assessment of DLT in multilingual children, because multilingualism has been more and more topical, and our aim is to provide equal services to all individuals. And for me, it was very special because on the one hand, I also wrote my master thesis about bilingual children, but on the other hand, now years later, I have bilingual children at home. So thank you so much for sharing your research and your knowledge about this topic and all the updates. It was really, really interesting. And I think it was very surprising that you said that 72% of those participants felt confident to assess bilingual children. I think that was very surprising. And
I may have to add that most of the participants reported that they had some long-term professional experience. So most of them had professional experience for 10 years or even more. And which is really interesting, you do not have to be bilingual yourself, and you do not need to have a test, a standardized norm-oriented test to identify DLD. And we think the more the professionals and clinicians were aware of this and also had the opportunities to participate in continued professional development, the more confident they became. Yes.
yes, thank you. And you also mentioned that barriers seemed less language specific. I think this was very interesting and surprising outcome too. But now I would like to open to questions. Right now I can't see any questions in the chat box. Am I correct? Please correct me if you can see any questions there, but there's possibility to raise hand. And as long as you're still thinking about the questions, I will ask my own. I would really like to hear about your experience in your country now. How has the policy changed during the last years? For example, do you have access to trained interpreters that you said would be a good thing? Or are there supervised clinical placements? Is there possibility for that? Or is it still needed to use the monolingual norm tests somewhere? Can you please share a little bit about that?
Oh yeah, I try. I will. If I forget one of those questions, please remind me. Yeah, actually, to be honest, the whole system still is rather monolingual orientated. This applies for school, for classroom settings. So, but you have to differentiate. In Germany, SLTs are rather working in a healthcare setting, but not in educational systems. So the educational systems uses still norm-oriented tests to identify whether a child in a monolingual classroom will get along with the teaching situation, which is rather monolingually, or not. But this is testing linguistic knowledge, but you cannot identify a disorder this way. So yes, healthcare workers such as SLTs rather use not norm-oriented assessments, but rather they sometimes say go back to dynamic assessment, because the idea of dynamic assessment is rather old if you think about Vygotsky, for example, or Feuerstein. So they think that even if they would apply a test, they cannot use a norm, but what they observe while conducting that test is much more. They can gain more knowledge about that. So even for orientation, they do not use or should not use a test, and this is what they are being aware. But still, there's still some pediatrician asks for a T value, you know, is it like 40 or not? We are working on that, and it's slowly coming into the broad clinical practice that people rather use a profound and comprehensive anamnesis, so taking the case history, asking for exposure rates, and identify that they're not really even the classic bilingual children. Most of our children, this is another survey, most of the migrant children we have, or with migration background, they're actually using 3, 4, some even 5 languages, despite only being in elementary school. So actually we cannot work with all the tests because they do not match the reference group. So we are working on our monolingual habitus. Diversity is becoming more true. We are adapting. We are in transformation, like we are in transformation processes with using AI. So some still feel that the whole foundation and ground they were educated in
is being, it's like an earthquake in our educational foundation, but we are learning, we are adapting slowly, but yes, we are. I'm not sure if I missed another question.
No, it's good. Thank you so much for this answer. And now I see that in our chat box, is it the question? Because I don't speak this language, then please, do we have some colleagues who would like to comment on the comment in the chat box? It's not in English.
Microphone. Yes, I can say it in English because it's in Latvian. The biggest challenge for us is Ukrainian children. And for some SLTs, this author is saying it's good that she knows Russian language. If I do not know Russian, then it would be very, very hard, and support for these children would be very not so qualified. And there's one more, SLT writes that she's working with children from diaspora. She's in Spain for 6 years, and she have helped many children, multilingual children from different European countries and also from USA. I know that I, as a Latvian speech therapist, can help to learn Latvian, to speak Latvian. And this Latvian language for these children is as second language, not first, not mother tongue, because in main situations, mother is Latvian, but father is not Latvian. And this more challenge is sound pronunciation. And I can say that I can encourage every speech therapist to help to teach Latvian and to keep Latvian language, or anyone else. It was more, I think, not as a question, but as a comment.
Yes, thank you so much. And now, before we sum up, I see that Helja Möller would like to say something. Please, go ahead.
Oh, yes, thank you, Vipka, for such an interesting speech. And I would like to ask you, as a representative of Germany, it is always interesting to know in your traditions, in how many languages is there possibility to get SLT service? Is it officially, or is just the language that SLT can speak? So,
yeah, thank you very much. Actually, I'm doing another survey. We are just working on the analysis of the results, which is a study on our own profession. So we call it diversity representation matters. So we are just researching our own makeup of our SLT profession. So you get the data firsthand. Actually, it was surprising to me that we are quite multilingual, but we are not in the sense that we would have, you have to differentiate. If you speak more than one languages, many speak 2 or 3 languages, but they do not feel fully equipped to use all of their languages or both of the languages in therapy or for assessment purposes. So this is different. So we need to differentiate what we learned about languages. Clinical markers in one language are not clinical markers, but linguistic clinical markers. Not with the short-term memory, what I said, the processual base accounts for all. These are general or almost universal clinical markers. But when it comes to linguistic markers, we cannot use you have different markers in maybe aspect in Russia, in German it would be the verb agreement, subject verb agreement, etc. So we need, but if you
speak different languages, you are aware that you cannot transfer clinical markers from one language to the other. So this is actually the benefit. It does not matter in which language you are, which additional language you have and how good or profound you speak them or use them, but it's about the awareness that you cannot transfer rules and morphology or grammar, or especially semantics, and of course not vocabulary, from one language to the other. So this is actually the benefit. And yes, we are quite diverse. And what is interesting is we represent our heterogeneous population. In the younger SLTs, there are some who know Arabic, or one of the Arabic languages or dialects, you have to say. There are many. So if you speak Arabic, there are a huge difference, which you do not know about when you read or write Arabic. So, or Turkish and Russian. So we do speak different languages. However, I also know about colleagues who use Russian in exchange with clients from Ukraine. But actually, you do not, therapy is more than teaching words. It's not about teaching vocabulary. It's about interaction. It's about building up cognitive representation to allow or build on strategies for intake of rules or detecting rules. We all know about what therapy is about. So, but the solely linguistic focus is not of help. It's being aware and being open. And if I may add, I think in about 10 years from now, we will not consider that mismatch of languages won't be anymore a problem in terms of talking with parents or other clients about when to come to an appointment, what to do at home, these other talks we have. Not when it comes to therapy direct, but in the exchange or for case history taking, we won't experience challenges anymore. And this may be due to artificial intelligence. We may have the possibilities to, in real time, exchange and talk to people whom we don't share natively the language with. So I think those barriers will be reduced due to technological transformation very soon. However, we may not assume that we have to work in the language directly. And actually, we have 167 different languages in Germany, to come back to your questions, and there won't be a therapist who will be able to work on all of that. I think we have to think about SLT therapy in a different way.
Thank you so much. And thank you so much for this interesting presentation and this session. Time flies and we need to start wrap it up. But I would like to give the last word to my colleague Sarmite to wrap this very interesting session up for us. Thank you.
Okay, thank you. Thank you very much. Thank you very much, Vipke, for your presentation. It was really, I think, helpful and useful for all of us. There is one more question, but I will write it down in English, and you will maybe answer later on this, because we really don't have time. And thank you for the link you shared. I think it also helps us. Thank you, and hope for further cooperation again.
Thank you very much, and I wish you a continued successful Congress. Thank you very much for having me. Bye-bye.